Hey Matt, how you doing?
Not bad. A little tired. I was in about till like 2 last night, but good otherwise.
Good to hear.
How are things up there treating you?
Good. Just busy, but luckily I had a light clinical month this month, so it's been able to recoup my batteries, I guess.
Nice.
As usual, well, let's start at 105. I'll make an announcement to 105 because next Thursday is Thanksgiving, so we're gonna take a break and then but we'll give everyone till 105.
Are you able to see my PowerPoint right now?
Yeah, I am.
Hey, Matt.
How are you?
All right. Who is Sean Jenkins?
Somebody who wrote a check. I'm not really sure. Like,
Is this a famous person I'm not aware of?
it's
A rich person
Somebody
I'm not aware of.
somebody down here wrote enough money to get their name on a hospital.
God bless him.
Some local philanthropist. I probably should be able to say better since I have his name on a lot of my stuff, but I don't remember what the actual price tag is to get a hospital named after you. And hopefully it doesn't become like one of those football stadiums where every few years there's a new cell phone maker that's now sponsoring the stadium.
In Atlanta, it was $200 million.
Oh, okay.
Yeah, back in residency it was 50 million. I'm sure that's gone up some.
Yeah, no, we're building the Arthur M. Blank Children's Hospital, $200 million.
Nice.
If it's not the blanks, it would be Coca-Cola if you're in Atlanta, I guess.
Yeah.
Bernie Marcus.
Birdie Market. Real Housewives, do they contribute to anything?
All right, good afternoon, everyone. Thanks for joining this week. Today we have Matt Moake from South Carolina today. I also want to give an announcement. So next Thursday is Thanksgiving here. So we'll be taking the next week off and then resume the following week after that. And Matt, thank you for presenting again, and you can take over.
Cool. Happy to be here. You can see my slides okay?
Yep.
Cool. All right. So like you said, I'm Matthew Moake. I'm down here in Charleston, South Carolina, at the Medical University of South Carolina. Purchased apparently, or sponsored by Sean Jenkins, whoever that is. I have no financial disclosures, and for those of you who can actually see my face on this, I apologize. I agreed to my fellow's request in the no shave November, and I'm under no delusions whatsoever. This is a good look for me, but it's lasting for a couple more weeks, and my wife will be very happy when it ends. And so this one actually turned 40 Monday. And so as I was building this, I decided I was going to make it a little more playful, sort of a over the hill birthday edition. And with that, kind of focusing on two general themes. One is things that hurt, and other sort of being some more adult problems with, and I'll chat a little bit later, our group, sort of like what Erica talked about a couple weeks ago. I'm sort of this pediatric stepchild in a larger adult group. And so covering some of the path that they've had recently, which I thought was, rare stuff that we potentially could see in some really nice ultrasound imaging otherwise. So with that, we'll get to first case. And so this is a patient that I saw who came in with kind of neck and, what's this? Okay. Patient with neck and chest pain. So it's a 22-year-old male sickle cell patient, and we will see in theory through 17 and then specialized patients up till kind of whenever our negotiations with those specialties cap out. But 22-year-old male with sickle cell coming in with 1 day of left neck and sort of chest shoulder pain. He'd actually been discharged just a day or two before after being in the hospital for like a week and a half for an acute chest episode. And during that time, he had a Lyme culture that grew a funky mycobacterium, for which he was on multiple antibiotics ongoing. And he sort of casually noted when we were talking to him that his port had started to like act up on the back end of his stay. So this is what he actually looked like. And so those are his photos. And so the discoloration over the port itself, he said, happened every time he was accessed and was sort of a local skin reaction to tape. But you can kind of get a sense looking at sort of the left side of his neck and sort of like trap area in both these views that there was definitely clearly some swelling. His exam, so he triggered our SWAT clock when he came in febrile and tachycardic. And so I had to sort of get in the room as soon as he was triaged in. I took one look at that site and said, nobody touched that. And so ended up putting in a big ultrasound IV and doing our usual like SWAT sort of order set with antibiotics, cultures, labs, and then promptly sort of slid right over from there to start looking at sort of this area. And I had some suspicions of what I might find. We wanted to take a look. And so that whole area was tender, and he pretty much refused to lay back even for the IV. And so started out here on the left, kind of this is sort of just superior to his port. And you can see some of his sort of tracking tubing in the sub-Q tissue. Slowly kind of followed that up the neck. Looked like he had kind of a little bit of skin thickening, but nothing like overwhelming in this sort of the soft tissue area. Slid up and kind of continued to follow, and you can see the tubing coming in this area. And then something caught my eye, which was an area that I was planning to get to coming in sort of the bottom of screen left. Anybody sort of take note of that? Yes, it did definitely look like so. Kind of this little guy coming in right here as I was sort of moving up his neck sort of caught my attention. And so slid over to sort of focus on that and drop the depth a little bit and tracked it up more. And so I had his little neck intussusception coming up here. Could see carotid, or there's certainly vascular pulsatile coming up. And then you can actually make out now what I thought I was seeing, which was probably his IJ. Now actually be able to make out the lumen sort of hanging out there. And then the whole area just surrounding these looked irritated. So hyperechoic, definitely mad looking tissue. Went up and looked at it a little further. Now this is sort of like mid neck, kind of right at the end of where that little bit was. And so you can see kind of nice distended jugular vein. I'm intentionally not doing much in the way of pressure here, both because it hurt and also I didn't want to make this any more angry. And you can see as you kind of go from a little bit more up his neck, just back down, you can see the end of this nice little Goomba hanging out in here. And you can see it's got some flow around it, but it's obstructing most of that with good, clean carotid flow here. And turned and took a look in long axis. And you can see this big old fat fella hanging out, pretty much fully obstructing the lumen of his IJ. And that sort of extended all the way down into the base of his neck as far as we could see. So I see from the comments, so Lemierre's, this was certainly, IJ septic thrombophlebitis given his fever, tachycardia, and like the exquisite tenderness he had. And this ultrasound certainly was my also running impression. I will be interested to know if the groups from like a technical stance, I classically think of Lemierre's as a extension from like an oropharyngeal infection causing this, whereas he didn't really have much in the way of oropharyngeal complaints, but he certainly had a big old angry looking clot with a lot of sort of kind of hyperechoic changes around the vessel. So he got the SWAT on arrival. We ended up with the ultrasound. I kind of turned to our nurse practitioner who actually took him and asked her to broaden up his antibiotics and go and get working on some anticoagulation, sort of paging the HEMONC team sooner rather than later. Their response was promptly, well, like, how do you know he has a clot? For which I made several under the breath and not so under the breath comments. His labs came back sort of notably inflamed, as you would expect. The rest of his infectious workup, as far as like other sources of things, came back negative. The HEMONC fellow was promptly like, get IR and have him take the clot out now. And IR promptly laughed at them. And so he ended up admitting, coming into the hospital, got his port taken out the next day because of the clot, and then was ultimately on a drip for a while and converted to Eliquis and went home. His culture never actually grew anything, at least as of the last check, which was quite a ways out. But this is one was that was sort of what I was concerned I might find, given the acuity and the problems with, was it ACS action Lemierre's? I don't know. His port had seemed to be working fine, and the swelling that he had, he said, was very dramatically like the day after he left the hospital. So they ended up getting a radiology ultrasound with this and showed that that clot actually extended all the way down into his brachiocephalic as well, which is where his line itself actually was a subclavian line, but it wasn't fully occlusive there. And so he discharged and is doing fine, at least as of now. Second case, and so this is an image I put up the last time just because I love it and I feel like it's very, very practical for a lot of things we do, is a case of some lower extremity pain. So this was a case that was actually handed off to me. It's a teenage male who was there with left lower extremity redness and pain. He'd had a bunch of like odd traumas over the preceding month that like got hit with a football helmet, had some swelling, went away, had a little cut, like hard to know if any of them were related. But a few days prior to his presentation, he developed redness and swelling to the area and actually come in the day prior and been seen on the first round by the same attending both times. Had an ultrasound done then, didn't show anything drainable. Ended up getting switched from a variety of antibiotics he'd been put on, including a dose of Rosefin and Bactrim at some urgent cares onto some Clinda, and came back just because he was having ongoing swelling, ongoing swelling, redness, was febrile. And so wanted another round of evaluation. So this is a picture of his leg. And so his primary focus of pain and sort of swelling is this kind of medial distal aspect of the kind of inner lower leg. But he had a sort of extending redness that they marked, really extending the bulk of the way around the lower extremity. He was actually afebrile and looked pretty well from a vitals perspective in the ED, a little tacky. It was definitely painful. And he was a pretty anxious kid overall. Much to my chagrin, and the other thing you can see in this picture is the radiology ultrasound machine sitting in the background, because when I was getting him at sign out, they had ordered an ultrasound to look at this, for which I gave my second-year fellow who was on from the daytime and overlapping with me a good dirty look. And that, as you would expect, limited to come back with an abscess. And so we were discussing, what the best way to go about this was. And here is a shot of our images that we did, and we were sort of prepping to deal with this. And so this was a pretty substantial sized abscess and went pretty darn deep into his leg. So this is a long axis kind of going. So cephalad up here, kind of tracking. This is sort of anterior tibia here. And this is tibia sitting in sort of cross section. And see big fluid collection, pretty deep and really getting down right next to the bony area. And so I'm curious from a group perspective, what you would do with this next, given sort of where it is. He had Radis done twice. He had it done the day before and they said no drainable fluid collection, which I find hard to believe looking at it. And then he had it done right as I was coming on in sign out. And so given kind of depth of this, and I'll say he had a CRP of 30, was febrile, had sort of tracking erythema going up, and this went right down to the bone. What would be folks' approach to this? And like, how would you, if you were going to do something to it, how would you go about it for pain control?
Matt, did you put any flow on it to see if there's any blood vessels around there?
We did. There was nothing hazard wise.
So Matt, the thing that concerns me here is how close it is to that bone relative to the soft tissue. And so, the concern would be where this infection is originating from, if it's, an osteo and abscess versus just all SSTI.
Yeah. And that was my big concern, was that this kid had this like month of like weird, a bruise here, a cut here. Could this be something that had seated deeper? Clearly had a drainable fluid collection. And so, this needed to come out, but like its proximity to the bone and how deep it was. And the kid was super angsty. And so I kind of had a discussion with families, like, I'm not sedating him for this. A, he's older than I like to sedate, period, just on like you should be able to tolerate it. And B, I told him, I think there's decent odds that he's going to need more done with this and could need an operative washout, and may have MRI and whatnot coming in his future. But there was clearly stuff that needed to come out and he's pretty uncomfortable. So what we discussed doing was giving him a block to get this taken care of and trying just a bedside IND in the ED, figuring there really shouldn't be much harm to that. Even if it was a deeper extension, even need a surgical like washout, they would have to go in there anyway. And conveniently, his distribution fit pretty nicely to the saphenous distribution, sort of right along that inner aspect of the lower leg. And so this is one that you can kind of do blocks on a couple different levels. You can go up and sort of do your kind of adductor canal, which I think is a little bit more arduous and puts yourself in a little bit more risk for badness. What I have done a couple of times now is gone to this sort of paravenous approach, sort of just below the knee, which is a very straightforward approach. This photo kind of demonstrates sort of how I have done it. This is actually me blocking myself in conference one day. And this is one of the few times I've actually done the block like outright. And I will say, I didn't think it worked initially because I spent the entire day pinching myself and was like, I feel something. And then the next day I was completely covered in bruises in my entire like inner aspect of my shin, and realized just how hard I had to be pinching myself to have any sensation. And so really to do this, you just tourniquet right below the knee, and you can actually do it without ultrasound if you have a body who has a nice prominent saphenous. So this photo on the bottom right is actually our ultrasound director here, who had managed to tag himself pretty good kiteboarding. And he's a much more impressive physical specimen than am I. And he was able to just tourniquet himself at home without ultrasound. And all you really do is come in and dump anesthetic really on either side of the saphenous. If you can see the nerve, great. You can sort of target it more specifically. But in most cases, I found I don't really see the actual nerve itself, and just sort of target to both sides. And so this was sort of my fellow doing this, and just did as an out of plane technique the same way you would do an IV, only in this case, his actual saphenous vein is hanging out right here. And she just dumped about 5 cc's of anesthetic on one side, then slid over, lined it back up, and went on the other side. Leigh, I see your comment with just a tourniquet, not a cuff. I have usually been able to get this with just a tourniquet. All I'm really looking for is to see, same way I would basically do this from a vascular access, just enough to make out where the saphenous vein is, so that I know where to not hit and then where to sort of, infiltrate around. And so we did basically 5 cc's on either side, and you can kind of track around the vein after it happened. You could see that thing was nice and puckered and got a good load of anesthetic by it. And then from there slid down. Oh, no beer block. Slid down and then was able to sort of get into this thing. We actually had him do it under ultrasound guidance with the initial poke, because the way his sort of fluid pocket looked like it should be from like palpation really wasn't how it sat deeper. So we sort of lined it up and then it sort of stabbed in. You can see kind of a scalpel coming in. This is one of those, we fully exposed an 11 blade and basically hubbed the thing to get down to this pocket, and did a lot of digging around, and he tolerated it really well. And in the end, got a ton of pus out, ended up admitting him because he'd been on a variety of antibiotics and had such an impressive, and I had sort of prepped mom that this would probably end up with further imaging, because I wasn't sure that this was going to be definitive. He ended up getting an MRI, which didn't show osteo and just showed sort of, this sort of nebulous fluid collection that looked like it was being drained well with the vessel loop that we left in. They had surgery come by and look at it, and they said, yeah, this looks fine. We wouldn't do anything else. So in the end, we were actually be able to give him sort of definitive drainage, with just this simple block and a bedside IND. He ended up doing fine. Questions about that one? So another fun and very easy block to do that really doesn't even involve seeing the nerve and gets you a nice little coverage of the inner lower leg. So next up, and this is a case that I had, it was more of a scan shift, so I wasn't the clinical decision maker, but we were kind of in around at the right time. So this is a little kid that's coming in with some knee pain. There's a 3-year-old who's had right knee pain and swelling. He'd been running around and playing, and sort of grandma noted that like 6 days prior. Oh, sorry, looking at the comment for the last case. It was a pretty substantial sort of volume of just standard old nasty looking pus. But it was a lot. He had a pretty good cavity. We put 2 big incisions, dissected around into that thing quite a bit with some hemostats, and left a large vessel loop in. And all they did in patient was do compresses and kind of, floss the vessel loop a couple times a day. So this kiddo, I've been running around, and grandma noted he had a decent fall right onto sort of his bent knee about a week prior. And he'd had progressive swelling in what she was describing as pain afterwards. Overlying skin was fine. He was afebrile and otherwise sort of systemically doing well. This is not his knee, but this is sort of a representative of what his knee looked like. We weren't on top of him enough to take a photo of his knee, but really diffuse swelling that was definitely over the knee joint, but extended, reasonably up into sort of the distal thigh as well as into the upper lower leg. No erythema, really wasn't tender when you pressed on it. And the kid would walk around, but you'd like see him go over to like bend over, and he would like squat, and he would clearly stop because of the knee. And it looked more like it was probably just a physics issue of like volume there. And he had completely normal vitals. And so went in with IFL on a scan shift. When we kind of overheard this, they were talking about doing an ultrasound, and we're like, don't you dare. And so looked, long axis of the knee. So kind of standard anatomy here, distal femur here. Here's his growth plate, patella, and given his age, he's got a whole lot of cartilage sitting on that. Quad tendon hanging out here. First and foremost, wanted to see if we had a joint effusion, and certainly didn't see anything prominent here, kind of no, synovial fluid, hypoechoic fluid dissecting between the fat pads of the upper aspect of the knee joint, but a whole lot of sub-Q thickening here. This is far more than any sort of like, normal knee should have hanging out on it. And as we sort of played with this a little further and started to kind of let up our pressure from where we were at, we realized that not only was this a bunch of soft tissue edema, but there was a pretty prominent fluid pocket hanging out in there that we were initially just sort of compressing itself, and so we weren't actually seeing it. And as we let up, we were able to see, and it had this nice chunks of tissue kind of hanging it that were pretty similar echogenicity to the surrounding tissue. And as we sort of like lightened up as best we could, this thing was about 1 centimeter deep, but cleanly above the patella and sort of quad tendon, which you don't really see very well here. And as we tracked it kind of proximal, moving now more distal, here's sort of patellar tendon going into distal tibia. And this pocket extended, well beyond sort of the extent of sort of standard bursal structures, which is what the first time we saw the pocket, I was wondering if this might be a little traumatic bursitis. But well down, all the way into from sort of distal femur extending down into proximal tib, but well above sort of the quad patellar tendon complex, so cleanly not in the knee joint itself, which made sense given the rest of his exam and systemic kind of lack of symptoms overall. And so, have folks seen this? What do you think this is? I'll see what my participant list is to know if I've got it planned.
I mean, one of those quips, it looked like something was quivering under there. I don't know if that was the person's hand trying to hold still, or if that was the tissue. But if it was tissue, I'd be concerned about a muscle tear with resultant hematoma in there.
Yeah, so like my initial thought when we got sort of like this first, as we sort of let up and saw a little bit of fluid right over the knee, I was like, this is the spot for the prepatellar bursa. But as it extended further, it clearly extended beyond that. And it actually occurred to me that I'd seen something very similar like this before in this venue, compliments of Dr. Kate Dinahan. So this is comparing affected side, and then this is an unaffected side. So you can see just how much, extension of this sort of soft tissue edema and fluid this is compared between like what should be sort of this normal space here. There it is, Dr. Cohen with the win. So Kate had presented a couple months ago, actually, after this had sort of popped out in PEC, a Morel-Lavelle lesion, which is a degloving injury. And so her case was a teenager who'd had sort of a mild MSK injury and had this sort of more like I believe it was medial knee swelling. And if you look at that paper, the images are basically spot on. So this fluid collection with some surrounding kind of tissue edema, and then like basically what looks like chunks of like fatty tissue floating around in it. And what it is just a degloving injury. And you shear some fascial planes and it leaves this potential space. And so this is what I thought it was after sort of recalling this. And I pulled this paper and gave it to our fellow who was on. And this is what I put in my little addendum into like my ultrasound note. They had got an X-ray, which the radiologist called pretty quickly and like, man, this is some impressive swelling, kind of extending like mid to distal thigh all the way down to the tibia. Got some inflammatory labs, and this was not me doing the running here, all of which was sort of as expected, totally sort of non-inflamed. And this kid at one point was literally being chased by a nurse around the nursing station, trying to catch him, I think perhaps to get him back for his IV. So the attending on is a little more conservative and consulted ortho, who came down and recommended, as I feel like specialists tend to do, more things. And so wanted to admit him. They were concerned that he could have an infection there, despite his overwhelming lack of skin changes, inflammatory markers, or really tenderness to this area. They did not get any other imaging at the time. And then the following day, the inpatient peds team had radiology do an ultrasound, and not to my surprise, was the exact same thing that I'd said I thought it was. And the kid promptly went home. And I'm curious for folks kind of in this setting when you're on, so like, we all do scan shifts with folks. I debated sort of during real time and then sort of in the retrospective scope, how much I should have lobbied to our team itself, how to manage this kid based on sort of what I was seeing and what I was telling them I was seeing. Because if this were me, I think I might have gone down the inflammatory labs route just to cover my backside. But once with these, I told a fellow like I would have sent that kid home. And I felt pretty confident calling it a Morel-Lavelle. I don't know if I'm saying that right at all. But I'm curious, like when you guys are on scan shifts and you've got findings, like how do you sort of dance the interpreter, give info, but like also avoid giving your own kind of management style to that, since there's obviously lots of ways to handle any given presentation.
I think it all depends on the case and how comfortable people are with whatever the reading is. So if they're unfamiliar with, the description that you're giving, then they are going to probably go ahead and do all the normal things they're going to do. But if it's a more cut and dry differential and you're giving them the thing that's an expected outcome, then I feel more often than not, they just go with whatever our reading is.
So, I mean, I didn't figure he already had an IV, like giving a little antibiotic wasn't a big deal. Nobody was threatening sedating this kid or sticking a needle in him. So I didn't think it was like particularly harm to him. And certainly I think if there had been something that I was like, this is outright like harmful, but because I ended up doing a lot of these where I'm sort of lingering around doing various teaching and get asked to do odds and ends stuff. And it's always a balance of like, how much do I, how consultative versus like more definitive should I be based on what we're looking at and folks don't see. Cool. Next up is a young boy who came in following a rat bite. So he was seen by one of my colleagues who was there, and it kind of was sort of the other attending on the time. So it's a 4-year-old healthy male coming in. He'd been bitten by a rat on his left third finger about 3 weeks prior. Impressively, his family cat had caught the rat, and therefore, like, DHEC was able to process it and prove that he didn't have rabies. So that was good for him. He saw his pediatrician, who put him on some amox. He had kind of progressive redness and swelling, so they switched him to Clinda, which resolved the redness and swelling. But then a few days prior to his ED visit, he had return of his redness swelling. And the family noticed a little bit of discharge from his site and also like this kind of cracking of his skin. But he was otherwise well, no fevers, and running around doing normal kid stuff. So here's a photo of his finger. And I sort of saw the photo and was listening to the description of it. And he was tender, obviously erythematous, and these nice overlying skin changes. Tended to keep the finger in sort of this flex position. And so with the discussion of what they were describing, we're discussing, could he be just this basic soft tissue infection? Could he have something in the joint? Could this be involving the flexor tendons? And so we went in to go in and ultrasound him. And he was a very impressively like intuitive 4-year-old. I came in with a water bath and he probably hopped up in the bed and smacked his hand right in the water. So this is looking sort of dorsally, sort of top down at the finger. This is his PIP here. And this is a fairly clean, sort of nice sort of phalanx, and then sort of his proximal sided growth plate here. And you see sort of physis, metaphysis all hanging out here, nice and sort of structured. And you go to the joint with sort of the most erythematous here, it's kind of clipping off the back end. Phalanx is sitting here, and you really just don't make out, you don't see that sort of proximal piece of the growth plate. And this whole area is a little bit of fluid collection and a whole lot of more kind of like scattered little hyperechoic bits, but none of that organized like physis we see at the PIP. Flipped him over to get another look at it. So here's our PIP again here. So, lesser affected certainly. And then his DIP here, you get another sense. So here's the phalanx. You're just not seeing much of anything from that like proximal epiphysis here, kind of all this like little bits of sort of scattered hyperechoic bits. You can actually get a sense that like the alignment here just doesn't look quite right as well, relative to sort of the joint space here. You can also get a nice look at his sort of flexor tendon, and it actually looks pretty clean. And so this is his X-ray. And so you can appreciate, he's got this angulation off to the radial side and just total loss of that joint space architecture. So, the physis is basically gone. You don't see the epiphysis here. And then he's just got this ratty, like chewed up osteo looking bone. And so ultrasound pretty much matched the spot onto what the X-ray looked like. So he actually had pretty impressive inflammatory markers. Ortho admitted him, washed it out, did an arthrodesis on it. He ended up growing Pseudomonas and went home with 4 weeks of Cipro for this. As sort of a corollary to this one, this is sort of what I was anticipating potentially seeing on this. So this is an adult patient from one of my colleagues. This is a guy who was seen in another hospital for some chronic like lower extremity like angioedema pain. They tried a bunch of times to get an IV in this hand, and pretty much following his discharge, he had left third finger swelling and pain. You can kind of appreciate it here from the back side. This finger relative to the others is less impressive on the palmar side. And not only did he have swelling, but he had this persistent kind of flexion that he didn't want to straighten out. And so this was my colleague's ultrasound using the same kind of water back technique, looking at sort of the palmar aspect of his flexor tendon here. And this is his affected finger versus an unaffected finger of the opposite hand. And what you can see here is sort of a little bit larger tendon with, you've got these sort of scattered little hypoechoic fluid collections along the extension of the tendon. And so this was one of the things I thought I might see in another kiddo. So this is a fairly classic looking flexor tendinosynovitis. This one, the guy also ended up having some lower extremity cellulitis. So the ED team had consulted the hand specialist who came and looked at him and said, no, this isn't that. This is just sort of soft tissue inflammation. Admitted him for antibiotics for the lower extremity, went home, followed up with hand surgery a week or two later, who ordered an MRI, which came back as flexor tendinosynovitis. So that was filed away in my colleague's set of frenemy, like, I was right, you were wrong file. But sort of a similar potential looking clinical presentation with different looking sort of sonographic path here. And for anybody who hasn't done it, making use of the water bath for this sort of small, like hands and foot imaging when you can, or lets you see this architecture well. And so this was one, again, that one of my adult colleagues had done. And so the next set of cases are all adult-based cases that we have looked at together. And so I wanted to give a shout out sort of to our adult crew. This is Drs. Barnes, Shaw, Oliva, Cummings, and Presley, who are my adult colleagues. And, you know, great group of people. It's, we do every Wednesday mornings, our ultrasound conference review path from peds and adults. And it's great for discussing sort of path that we don't get to see on the ped side, but also like management and just like general good fun. And they're all a bunch of great teachers. And this is sort of odds and ends stuff of us practicing. This is Dr. Barnes tolerating some endocavitary probe, doing some PTA evaluation. This is Dr. Shaw getting his sort of brachial plexus looked at my house, and we were practicing the Raptor technique for infraclavicular blocks. And this is Dr. Cummings sort of supervising one of my fellows doing a PT block on me. It's a good group of people with some great path, and very fitting for my, as I'm getting older and wondering how many of these aches and pains now actually I need to take seriously, which is sort of my theme for the next two cases. So this next case is somebody coming with chest pain. And I have long mused on how long I should wait for what I think is my GERD to be taken more seriously. So this is a 29-year-old healthy guy, obese, but otherwise healthy, no medical problems, coming in for evaluation of chest pain. He was sent over from an urgent care, but by his own vehicle, because he had a quote unquote abnormal EKG. And he'd been seen there because he had some chest pain started the evening prior after eating a meal. Described it as sort of a soft heartburn. It was constant, radiated down to both arms. And he had one episode of emesis the evening before. And sort of the pain was such that it gave him a little bit of shortness of breath. And I feel like I have had similar such descriptions of pain before. And I'm like, oh, this is reflux, but I keep joking, when is it not? So he came in, was tacky, hypertensive, was obese and diaphoretic, otherwise normal rhythm, no sort of extra sounds in his cardiac exam, clear lungs, normal work of breathing. Here's the EKG. So I will say I routinely from the ped side, we get EKGs here and there for chest pain, and almost everything ends up being, age-based changes, nothing's particularly specific, but this one even I look at and I do not feel good about. So, ST changes in pretty much all of his precordial leads with corresponding reciprocal changes in sort of 2, 3 and AVF. All of these leads are pretty lousy looking signals. So he just with this got a STEMI alert, but 27, pretty odd age. So they went and looked to see if there's anything structurally how his function was doing, because he was good and tacky as well. So obese guy, so not like the best windows in the world, but here's his parasternal lung. And for each of these, I have included from the auto sort of advanced cardiac text, the corresponding kind of vascular perfusion maps for the heart. And so, kind of judging this, what do folks think of his function, and what do you think of that function as sort of a global versus any areas that seem like they're pulling their weight better, pulling their weight less, anything that looks like it's more like regionally insufficient?
It's really hard to make out on this, but it doesn't look like a septum is pulling its weight. Free wall looks okay.
Yeah, and that was, that was their interpretation. RV clearly is kicking along. Free wall looks like it's doing okay. If you just kind of watch, like there's movement of the heart, but the septum is sort of kind of being a little lame duck here. Parasternal short, again, not the greatest, but similar sort of, you can see the free wall here seems to be bouncing okay. The proximal view, kind of septal side, is not well visualized, but you don't see a whole lot of movement in this area. And his apical forward is probably the best view. And I think here more convincing that apex, not doing a ton here. Septal side also, particularly kind of that apical end, certainly decreased into this area, whereas your sort of lateral free wall here seems to be doing okay. And this corresponds reasonable. So all of these corresponding reasonable well to an LAD lesion. And so, like I said, he got a STEMI alert on arrival. He had a trope that was over 8,000. Got started on sort of triple therapy, went to the cath lab and had, as both EKG and ultrasound sort of suggested, a large proximal LAD occlusion with a post-op echo that showed, some reduced EF of about 45%. Ended up also adding himself a new diagnosis of diabetes in this, which, so had some underlying comorbidity that was previously undiagnosed. But this is one, we don't see, obviously, we get lots of kids with chest pain, and peds, it's almost never the heart. But it's not impossible. And one of those, and again, certainly with my progressive age, it was like, oh man, that's really young. Similar young cardiac path patient, this time sort of playing over into the arrhythmia section. And I just love this from an IT side of the classic, you call them, what do you do to fix it? So just turn off and turn on, which never really been the way I thought of adenosine, but it really is quite appropriate. So this was now a 33-year-old male coming in with chest pain and sensation of a racing heart. He had been seen, or excuse me, he had woken up about an hour prior with the sensation of sort of racing heart and like a drenching sweat. Reported that he had similar sort of episodes before, but all of which were sort of shorter in duration and never had prompted him to present for care. And had absolutely no comorbidities, wasn't obese. Came in, his triage vitals showed a heart rate of 66, but on his exam, he was noted to be tachycardic to over 150. No sort of adventitious sounds, clear lungs, well perfused. Got an EKG and actually had a series of EKGs in pretty close sequence. So I left the times on here so you can see kind of what the timing is. So classic middle of the night patient. So 1 o'clock, so 1:04 here, you can see, and again, not a path that we see a lot, but pretty clear atrial flutter, sort of variable conduction on his first EKG. Only just a few minutes later, switches into sort of different rhythm where now he's getting sort of more of like a rapid ventricular response to his flutter. So a lot faster ventricular contraction. Adult colleagues sort of ultrasounding him in this to look for structural stuff. Again, he had no comorbidities, sort of like, why is he doing this? And so here's what he started getting. So how do folks feel about the way this looks?
Even when there's a beat, it doesn't look as good LV function.
Yeah. Not good.
The last time I had a case of this in kids was restricted cardiomyopathy. I think Stephanie was my fellow way back when.
And so it was getting these views. And so you can see, what seems like some coordinated ventricular contraction, but a lot of kind of like what probably is sort of the flutter that's going on here, or some, differing conduction of those in. Then as he's continuing on to sort of like minutes later with this, things sort of flip a little bit and you get a little bit more, little different change. And see, as opposed to like what seemed before, you're kind of seeing a little bit more atrial activity, but not sort of as consistent ventricular. Now you're getting sort of this, you see his mitral valves just kind of like all of a sudden kind of flapping along here in a little bit more irregular pattern. I looked up on the monitor, and then so his last EKG was 108. And so here's the long axis for this, and sort of sees this change, looks up on the monitor, and this is the reflected monitor, and then EKG now just like a minute and a half later. And so he'd flip from going in from like a flutter with sort of, variable conduction to a flutter with RVR, now into a full-on lovely little VTAC, or certainly wide complex of the Barency, depending on sort of, but pretty consistent wide complex tachyarrhythmia. So, a little bit puckering. The guy was still conversant, hemodynamics were holding. So they ramped things up, got some pads on, ended up in discussion with cards, putting him, going for chemical control. So put him on procainamide drip, and we're able to get his rates back to sort of 60s or 70s, was initially nauseous and had a brief dip in blood pressure, but ultimately those recovered with fluids. Admitted to cards, sat around for a while, and then like in kind of classic fashion, 12 hours later, cards came down, still boarding in the ED, and asked the team to cardiovert him, which was successful to put him in a normal sinus rhythm. And he ended up post that demonstrating some pre-excitation, WPW appearing EKG, which I didn't include here. And so he ended up getting an ablation, and luckily did not need a pacemaker afterwards, but fun sort of real-time view of kind of rhythm change that corresponded to the monitor. And then the last two cases are similar kind of appearing path, but sort of different etiologies. So this one is an elderly patient coming in who was presenting as a trauma A for a fall. And I remember, at least in my EM rotation days as a fellow, these were some of my least favorite, because it's an old person who basically was found on the ground. They come in as a trauma, you don't actually know that they're trauma. Was found by EMS down on the ground in her nursing home, had a little bit of bleeding from his forehead, was hypotensive and actually bradycardic, able to answer questions okay, and they gave him a GCS of 14. But because of the hypotension and sort of this concern for trauma mechanism, got the full trauma shebang. So he came in, was hypotensive, still bradycardic, was actually sort of by the report, not really in distress, had a little abrasion to his forehead, really no other signs of trauma, but was poorly perfusing with a thready pulse, but despite that seemed to be at an okay GCS. The ED team itself had done kind of an EFAST sort of modified rush to look for sort of sources for his hypotension. And in the documentation is listed as negative. They were doing their volume resuscitation, gave him actually we're getting some PRBCs, put him on an epi drip, and working on an art line. Had ordered sort of more aggressive imaging, at which point one of my colleagues, Dr. Shaw, came through on a scan shift and was basically like, hey, you guys got anything interesting, anything we can help with? And the team was like, yeah, we got this sort of hypotensive guy in the trauma bay, a little unclear why. We looked, he's got a little bit of LVH on our scans. And so the first couple of views are their kind of EFAST sort of rush exam shots. So started here. So first image is obviously chest, looking for pneumothorax. You know, nothing concerning here. Good lung slide, nice pleural sliding. Belly views here, so kind of right and left upper quadrant. Nothing certainly standing out. No obvious big chunks of free fluid. Fairly quick clips through, but if you look kind of upper quadrants, nothing obvious. Morris, nothing at its caudal tip, nothing obvious around the spleen. Swung to subxiphoid view where they saw their sort of concerns for LVH. What do you guys think of his LVH? So definitely not LVH. So big old fat, not hypoechoic like clear effusion, but sort of more echo dense. There's a little bit of hypoechoic staying around there. Big old effusion though. So Oldland kind of crew looked at those real quick and was like, oh, and sort of popped the probe on and got some more images, pumped the gain up, and you can clearly see sort of subxiphoid view here. Big old, echoic effusion with a little bit more hypoechoic stuff hanging out around. Measured it, almost, over 3.5 centimeters, and sort of the longest view they could get size-wise. So very large effusion. Took a look at the IVC. You can see sort of kind of panning across it. There's really not much variability in this thing, and it's not measured, but you can tell by the scale this is a nice, robust IVC. Parasternal long, you can see again, kind of looking effusion size. Try to kind of time out, whether you're getting sort of tamponade sides on the RV here. The other thing you notice, what do you guys think about the aorta here?
Dilated root.
Yeah, so certainly looks, not measured, but again, if you're going, this is sort of the larger boxes are 5. So certainly on the big side, little bit of insufficiency, not particularly impressive, but if you kind of use your standard the way I was supposed to have like 3 fingers of size coming off the LV, RV here, aorta certainly is significantly bigger than LA or RV here. So their concern was sort of dilation and sort of proximal aortic dissection with this, and that it actually bled into the pericardial space. So this is an aortic notch view. So pro-market patients right kind of peering down in to try to look at the aortic arch. And so should have kind of brachiocephalic left carotid and then sort of subclavian coming off with your pulmonary vascular here. And intermittently you see like this little bit of like something here, which looks more to be artifact than anything, but no obvious big dissection flap that could be visualized. It's certainly concerning based on, this complex looking, probably, blood in the pericardial space and dilated root there. And so kind of getting further info as they're continuing resuscitating and calling calling CT surgery and whatnot. So apical 4 here, you can see your effusion sitting around. Went to try to get some more advanced stuff to assess for tamponade. So color flow across your mitral valve, send your calipers up to look at mitral valve inflow here. And you can see kind of in between sort of respiratory variations, a nice change in sort of your E wave inflow. That was, in this case, it's listed as E to A, but effectively this is comparing your E to E changes with your respiratory variation, and nice prominent changes there. And actually snapped a photo from their monitor. And here was the guy's art line once they got it in. And so, your sonographic view of pulsus paradoxus and your art line sort of corresponding nicely to it. So while the source is probably not one we see very often, so, nice imaging of tamponade findings, and certainly not an impossible thing with our connective tissue kids who could have sort of aortic root stuff involved. This guy, given his age and comorbidities and whatnot, he ended up getting further imaging, which the CT showed an aortic intramural hematoma and likely hemopericardium with signs of tamponade, which sort of was already established based on the ultrasound ahead of time, at least for the tamponade side. Given his age and sort of what the source concern was, the thought was he would probably not be a good surgical candidate. They were actually admitted in the CVIC, were able to medically manage him with impulse control and just kept his heart rate and his blood pressure to sort of kind of acceptably low ranges. And he was able to be discharged. And then our last one. So this is a handoff patient for, I believe it might have been our first shift for one of our adult ED ultrasound fellows. And so this was straight from the note. So this was like the offgoing attending sign out. So 51-year-old female, recent GI bleed, fibromyalgia, hypertension, reflux, coming in with shortness of breath and epigastric pain for a couple of weeks. Fairly sort of specific exam. Otherwise, it was tachycardic. Had an EKG that had resulted that was sort of non-specific, just sort of sinus tach, and sort of plethora of workup ongoing, handed off pending, X-rays, CTs of everything. And there are her vitals below. So patient goes off, here's her X-ray, and with the X-ray interpretation hanging out here. So ugly, lots of things that seem like they're not supposed to be there. The fine details of the report comment on a large cardiac silhouette, which I would certainly agree with, and clearly have a pleural effusion hanging out here. The impression itself actually doesn't comment on the cardiac silhouette, which is interesting. Here was the CT that the fellow sort of flipped through and was like, oh. And so there's clearly your pleural effusion, but sort of the more concerning feature being this nice large effusion hanging around the heart. Always good to diagnose that on CT. So she called, and luckily one of the other attendings on was Dr. Cummings, is one of the other ultrasound attendings. And so these are paired images. On the left is their first images when they came out of CT. And the images on the right are now minus 800 cc's of fluid from around the heart. And so nice parasternal long, kind of got flipped to short in the end. This one you can pretty reasonably see that sort of as you kind of time out that mitral valve opening, you can see that RV sort of bouncing down a little bit, which looks a lot better once they've taken off that fluid. Parasternal short, sort of similarly nice big effusion hanging around that heart. That's much improved post-drainage. Here's your subxiphoid, similar sets of stuff. IVC comparison, sort of pre and post drainage. So nice plethoric IVC, dilated. You can sort of every now and then see that respiratory attempt that doesn't do a whole lot of changing, whereas here collapse is far better. And then here was their pre-post, looking at mitral valve inflow. And so nice changes, sort of E-wave prominence with respiratory variation. And here post-drainage, they didn't even bother to measure because everything was cleanly sort of running right across. I will say the drainage itself ended up being done. So from a management wise, they saw this, blood pressure was holding. And so they'd actually gotten lined up, got everything out, had even numbed for an apical approach, which is right when CT surgery. So CT surgery was actually the one that did the drainage. Amusingly for this one, as I was sort of doing the chart review on this, This is a quip from the H&P, and I thought it was hilarious that cardiology consulted and performed pericardiocentesis with 800 cc's straw-colored fluid removed. Due to continued tachycardia following procedure, decision made to admit to cardiology. Not the fact that alone 800 cc's of fluid being taken off the heart was enough to admit someone, but the fact that she was still tachycardic after it, which I thought was super amusing. The other amusing side of this, if you look at the discharge documentation, there's this all of a sudden new mention that the patient had been diagnosed effectively with lupus the month prior, which there's no mention in the ED note. And when you look at the charts, they'd been seen by family med who'd send a bunch of labs and then basically no follow-up whatsoever in the interval and no comment on these, ragingly high lupus labs. And so this was all in the end thought to be due to lupus, and just sort of kind of a big flop in what had been in follow-up to her primary care otherwise, which is super unfortunate. But she did fine afterwards. And that, I think, is the last of what I have here. And so despite getting older, these are my kids and my daughter, who is her usual very animated self and keeps me both young and ever graying. Questions, comments on any of those?
Matt, thank you. Those great cases hits home because we're not within the adult emergency department, so we're like across the street. So every now and then we get like MIs that they just get thrown in the front of us. It just says emergency, and they just drop them off there. So we get every now and then a lot of adult cases. So definitely worth the knowledge.
Yeah, I thought most of these were potentially applicable, although in rare cases, and they were just like, it was a string of like a month of like, just like great path from an ultrasound side.
But thank you once again. And just a reminder for everyone that we'll be taking next week off. Just enjoy the holidays, guys. And then I'll see you guys in a couple of weeks.